Iodine is another mineral we can measure. The body typically has 20 to 30 milligrams of iodine, which is concentrated in our thyroid gland. The rest is in other glands, the mammary glands, salivary glands, and also gastric mucosa and the blood. But its really main function is related to our thyroid hormone. It is required for synthesis of T4 and T3. Remember, thyroxine T4 has 4 atoms of iodine per molecule versus T3, triiodothyronine, has only 3 atoms. Iodine is absorbed in the form of iodide, and it occurs as both free and protein-bound iodide in circulation. Iodine is stored in the thyroid, where it's used for the synthesis of our active thyroid hormones. And the hormone is degraded in target cells and in the liver, and iodine is conserved if needed. We excrete it primarily in the urine, and small amounts from bile are excreted in the feces. In iron or iodine deficiency, we can see an enlargement of the thyroid gland, a goiter. We also could see deficiency can be absolute in areas of deficiency, or it can be relative in adolescence, pregnancy, lactation. Goiters are more prevalent overall, specifically with women, AFAB individuals, and as we age. We can see here that iodine deficiency is still the most common nutrient deficiency in the world. And we can see global distribution here of moderate iodine deficiency, mild iodine deficiencies, adequate iodine nutrition, and excess intake. And this is going to depend on area that you're living. When there's iodine excess, humans are really remarkably tolerant to high iodine intakes. But if we have iodine deficiency, repletion must be done slowly to prevent hyperthyroidism or even hypothyroidism. There can be a paradoxical goiter, which is enlarged thyroid as a result of really high intakes of iodine, which can occur in some countries that intake a lot of seaweed, for instance. Urine is the standard method for assessing iodine status and intake worldwide, and more than 90% of iodine is excreted in the urine, and therefore a random urine sample can be adequate for screening. You also could do an indirect functional assessment by looking at thyroid functional tests because they're a functional biomarker of long-term iodine intake and iodide status. TSH will be increased in iodine deficiency. Serum thyroglobulin concentrations will correlate with urine iodine levels, and decreased T4 with increased T3 could also indicate iodine deficiency. ZRT, which is a private company, does offer iodine testing using a dried spot sample of urine, which could be combined with thyroglobulin, TSH, T3, T4, and TPO blood spot tests for more of a comprehensive analysis. This is showing a iodine skin patch test. I do not use this in clinical practice, but it is something that has been used in the past. So looking at the bioavailability of iodine applied to the skin. This is looking at serum iodine levels following oral ingestion of iodide versus skin application overall. And we can see obviously oral bioavailability is much greater than skin bioavailability, although over time we can see at a higher dose, skin bioavailability does kind of get closer to oral ingestion. When we come back, we'll look at zinc function and assessment.